That's perfectly okay, Chuck. We are anticipating Latrina to join us again. I'm Ann Daniels. And can we do a quick intro again of those of you who are on the phone, on the call? Cheryl, Rachel,
Okay.
others?
I'm Cheryl Jordan. I just joined last week was my first meeting. And my interest, of course, is health and wellness because I see a lack of the abilities for our community to really work out and be exercise and have things that will draw them to want to exercise, which is one of the causes of the health disparities is the lack of movement. So that's my primary interest, is being able to have us move and be healthy and just stay moving, because the body at rest stays at rest, the body in motion stays in motion.
Good. You were quite specific this past week in explaining a lot of what we needed to hear. Rachel as well, want to reintroduce again, please?
Sure. Rachel Zimmer. I'm a doctor of nursing, and I run a mobile health program that provides care in different areas of Winston-Salem, specifically for people who don't have health insurance in the community. I also do a lot of work around health equity, especially when it comes to science, integrating community voice in areas of health and social justice. And then I ran a food prescription program for some time during the pandemic as well. So I'm specifically interested in food insecurity, addressing health equity, and I'm happy to be here.
Good, excellent. Excellent.
Hi, everybody. I'm Diane Schoenberger. I am a registered dietitian. I work for the YMCA, but do primarily outreach in East Winston, working on health and wellness. I work very closely with Rachel in the mobile clinic, working to see individual patients who have nutrition needs and other wellness issues. I connect them with resources, exercise, sometimes mental health services. And I also work with the Y in trying to facilitate resources for food insecurity.
Excellent. Anyone else on our call?
Yeah, this is Sandy Miller Jones. How are you?
Good, how are you?
Okay. I'm doing well, thank you.
Good.
I am the chair of SMSI Healthy Living Solutions. We're a national marketing outreach company whose primary mission is to help African American and Hispanic communities to improve their health overall. So we work with clients who are interested in doing that same thing.
Very good, very good. Anyone else? I am going to, I was prepared to facilitate with the work group leaders were to be Randall Pender and as well as Latrina Wofford. So I'm gonna work through this so that we can get as much done in the time we have as possible. I am a believer that of constructive change. In other words, if things were working well in Winston-Salem in health and wellness, what would it look like?
Mm-hmm.
And so we're going to try to work through as much as we can. What we don't finish, and I'm not suggesting we won't, we will have group in session 4 to be able to do some completion. So let's get right at it, if we will. I'm not going to spend a great deal of time, but I find myself begging to get adequate medical care for the autoimmune disease and pain I deal with. Pain in Black folks is viewed much differently than in white people. It blows my mind how a lot of people don't realize that Black people get the short end of the stick in healthcare. This is actually a quote that was provided to us by the project team. I serve on the project team with Chuck. In our last session, we looked at data. We worked on a problem statement, and I'm going to show you one that we capsulized, if you will, in the last session. And we're going to use that statement as a beginning point. But the object is to talk about, why does it exist? We know things exist, but the essence of where those of you and all of you who have expertise is to why the conditions exist and then ultimately to determine ways in which those conditions can be addressed. Go back here. Diabetes in health. Again, I won't go through all the details because that would take forever. I want to give us a chance to kind of thumb through there. Are you able to see the slide well? If you would just kind of glance at that, if you will. Those are some of the disparities that we talked about disparities, and we've added a slide that you might find at least intriguing about some of the data. I'll stop talking for a second. Is there anything that jumps out here that is of question or that we don't agree with or agree with but needs a twist? Talk, if you will, those of you for a second about what your observations are about the disparities in health in Forsyth County.
One thing that strikes me, I guess, I watched the Oprah documentary that I had sent, and one thing that they brought up that I thought was really interesting was that during slavery, infant mortality for Black people was 1.5, 2 times higher, and actually that has only increased. It has never gotten better. And then also pregnant Black women have always been at higher risk for dying, and that's never improved either. So these issues aren't new and they're not changing, they're worsening. And so I don't know if it's worth putting it on there or kind of stating that, you know, because I see that data is from 2014, but all of that still exists.
Absolutely.
You know? And so
can you state that in a term that I may be able to add it to a slide? There's a slide that's coming up in a bit. I'll be able to add that on there.
Yeah, let me think about it and put it in the chat. Can I do that? And then just add it as a bullet point?
That would be even better. As a matter of fact, as much as you can put in chat, because this is recorded, and that would be extremely helpful. Anyone else? In terms of
hypertension, unless it's covered under another category, I think that's really important because forever it was known as a silent killer, and African Americans were the ones that were dying from hypertension the most. And of course, it leads to kidney disease and everything, you know, strokes and everything else. So hypertension, if we can add that one, that category.
Cheryl, if you could put that in the chat as well. And please note, Cheryl and Rachel, that's slide 4, if you would, in your chat. That would be helpful. Anyone else, something jumps out at you that needs to be added or an issue that needs to be massaged? Anybody? If not, there will be chance to address that. Let's move to the next. There's some other disparities. Let's give you a second to take a look at those as well. And these are older studies, but if I'm hearing you all, they still persist even today.
Yeah, also, unfortunately, I think domestic abuse will need to be added to under mental health, because we see a lot of that now, you know, just domestic abuse, period.
Good. If you would put that in the chat, if you all can help me, that would be helpful. Add it to the chat with the slide 5. Anyone else? Anything else that really jumps out at you? Because we're going to get to some problem solving, or at least some identifying some problem statements. Anything else jumps out at you? You will have a chance to come back. Health equity. Realizing that health equity is certainly not health equality, is it?
No.
Let's just allow you a second to take a look at that slide.
Anne, could you make that slide larger?
I can. Let me see if I go up to,
You know, if you just for a moment, you put it in slide mode, in the
Yeah.
PowerPoint mode, it'll show up larger.
hold on 1 second. Let me move that slide. I'm gonna do slideshow
Right.
from the current slide.
Yeah.
Yes.
Perfect.
Okay.
And team, if something doesn't work right, feel free to say, and change that, okay? I am comfortable with that. Thanks, Mary.
Sure.
Health equity report summary. The 2 or 3 items that you all just talked about, is there something that overlaps or coincides with something here?
The only thing I'll say is the Hispanic Latinx population is not adequately represented well because there's such a lack of undocumented responses or people who are undocumented responding. There's the best data is even like we were just talking to a Latino research group and they're currently collecting information to better represent Latinos in North Carolina. And so I don't know if it's worth a footnote, I guess is what I'm saying, that Hispanic Latinos may be underrepresented in this graph just because of lack of data representing all people.
I think your point is well taken. If you could add that though in the chat, just as a thought, because as we get to look at problem statement, that could be helpful, Rachel. It's particularly interesting about the color. Mary was quite specific in talking about the color. And when you look at red, indicates a group is faring worse than the referent or referent group. Lots of red there, particularly for African Americans.
We're doing worse in all of the categories.
Absolutely.
Yeah.
And being equally disparaged with being overweight is not good news either.
Mm-mm.
No.
No.
I think, Cheryl, you talked about hypertension earlier, didn't you?
Yes.
Access to health, access to healthcare.
You know, what's interesting about the suicide is that there's a lot of evidence that shows that suicide risk goes down when you have good family support and relationships, which is actually a strength of the Black community. And older white men are actually the highest suicidal rate in America. So usually it's men at the age of 70, 80 that are at the highest risk for committing suicide. Just a strength that I thought might be worth pointing out, which is part of the reason why that's a green.
Interesting point. Interesting
It is
point.
interesting.
And I think we just learned today that Naomi Judd committed suicide.
Yes.
Yeah.
Yeah.
The other thing is all this data, most of the data that we're looking at captures up to 2019, which is pre-COVID, and all of these things have been magnified and mostly gotten worse, and suicide in particular. So be interesting to see how that impacts the data over time.
How might we talked about that, Mary, we talked about the 2014 data set. How might we be able to update these kinds of things? Is there anything that?
Well, in doing the search for the data,
Mhm.
And this is my speculation, was
Mhm.
that during COVID, this data was not captured and placed in report form. So I think that in 2022, later in this year, we should get a better read on this health equity report than we've received to this point.
Please
I'm
remind,
thinking pandemic had something to do with reporting.
please remind me of the group that does research here in town. I forget their name.
Forsyth Futures.
Foresight Futures.
Yes, is that something, or is that somewhere we might be able to capture more contemporary data or more?
Well, you know, in full transparency, we tried to get that,
I see,
but we did not get that. And
understandable.
Foresight Futures is who we had that contractual relationship with.
That's right, that's right.
And I did reach out to Elizabeth at Forsyth Futures because I was in a meeting with her and just told her that you might be reaching back out to her again. So
Great,
she's
thank you.
expecting that you might need some follow-up questions.
Good, good.
Thank
We
you,
talked-
Rachel.
No, we did talk about that. Is there anything else here in terms of our time? Is there anything in here that jumps out in addition to what we talked about that needs to be highlighted?
I'll
if
check back later, folks.
Great, thank you so much.
All right.
If there is something, believe me, we will come back to that. Now,
Sorry, there's one thing. And I think that you were asking for better representation of like current data. There is some data on the colorofcare.org, which is that Oprah webpage that just opened up, that does have very specific health related disparities for Black people compared to white people. So
Rachel,
I put it in the chat, the colorofcare.org. But if you go into the section that talks, hold on, I'll tell you for sure. Statistics at the top, it'll give you a whole list of stuff.
good, good, excellent, excellent. Well, we're at that point where we can do something or talk about something that's definitive. We're going to revisit the problem statement. We'll determine if it represents the essence of the disparity that we seek to address. We're going to ask why, the 5 whys. That's important in all phases. And this should get us a bit closer to finding or determining the root cause of our problem. We're going to create a vision statement, although we're not going to address necessarily steps in the vision. We are going to at least begin to create a vision of what that would look like, much like what I said earlier about constructive change. Well, if things were working well in health and wellness in East Winston, in Winston-Salem, North Carolina, what would it look like? And so that's a part of what we're going to be talking about. Identify the assets in the community that will support the vision that we confirm. Is that a lofty goal? I hope that you all have a couple 3 hours this evening to address.
It's doable.
Yes, it is. It is. And I appreciate your thinking positive. I'm having to move you all around on the screen so that I can read. Connect to and revisit the mission statement. Review the mission that's tied to disparity. Revisit the problem statement that we developed in the last statement, and I'm going to get to that. Now ask the why. A lot of this has to do with the purpose and the goal. The primary purpose of this work group, of our team, is to address health disparities that have caused devastation in the Black community. So what is the essence of this problem? Describe the problem. And I believe 5 bold steps. This just gives us another overview of what we're seeking as we look at the problem statement. This gives us a broad stroke of the vision here. There are supports, there are values tied to our vision, there are bold steps that we need to take.
Mhm.
And certainly there are some challenges that need to be overcome. Now, there probably will be several steps, but we're going to look at the top 5 essentially that we're trying to at least address in this session. Statement. What is a problem statement? I'm not going to tax you all's intelligence because you've done this 20 million times before. These are things that you address every day. So rather than spend a lot of time going through this, just want to make sure that we're looking at a problem statement. There are several problems, but in terms of at least one that we can reach some consensus on, not necessarily full agreement, but something that we can, after looking at the alternatives, a problem that we can live with, that we all can agree and live with. That's what I determine consensus.
Where we were, I'm sorry.
No. Just stop me anytime.
Oh, no, I was just gonna say where we were last week, well, the last meeting about, you know, that African Americans live longer with the, you know, these preventable diseases, but we die more frequently. I think that's where we were with a problem statement.
Absolutely. Let me go. I added, I'm gonna
Yeah.
go forward. I added a statement and I gotta see which one it is. So allow me to thumb through here. As a matter of fact, Latrina captured. She captured the statement and I typed it in there. So why can't I find it? This goes, this just goes, no, it actually is a statement. It's a written statement that she reminded me of, and I put it in the slides so that I would not have to fumble. And therefore it goes to show you all how organized I am, right?
Go back one statement, one slide. That one right there, that's not it. We die at an early age at a high rate of preventable diseases.
That's it, right there. That is exactly the first take. Thank you. I had written. We die at an earlier age and at a higher rate of preventable diseases. We live with more chronic diseases, reducing our quality of life.
Yes, yes, absolutely.
All of you, please comment on that. And is there a particular wording that needs to be tweaked a bit? Anybody, please. Great.
I would just add because of racism. I would be explicit. It's not your fault that you're dying at earlier ages. It's not because you're unhealthy. It's not because your community is, you know, whatever. It's because of racism. Like I think the ownership has to be transferred.
Yeah, I think that last why, when we have to ask why 5 times, I think that's where it'll end up. But in the meantime, I think it has a lot to do also with a lack of education on the way we eat. But you know, that's over in the food, I guess, a component of the whole Winston-Salem Rise. But it's education and lifestyle. But it all comes down to we talked about it last week. We're bombarded with ads and things that promote a lifestyle that's not healthy, whether it's smoking, drinking, fast food, unhealthy eating, unhealthy, you know, just behaviors that's the image that's put first in the community. You know, we don't have the cigarette billboards anymore. We don't have beer billboards anymore, but still we have a corner store that has cigarettes for everybody. And we have the industries that are in the community. So the community, our community, East Winston, is bombarded on every side. Like we said, we have an airport on one side, we have a Highway 52 on the other side, we have industry. You know, we had that Weaver fire thing that, that was blowing over the city a few months ago. Everything is just surrounding us and just closing us in, where we just don't have the opportunity to breathe. Just the one basic thing that we can do on our own is just breathe healthily, walk healthily, down the street without having exhaust from major highways coming into your community. And
Mhm.
so our lives are so defined by just in things that we can't control and can't change. We can't change industry. We can't change the pollution. We can't change the advertisers that want to come into the community. They're coming to your phone because everybody's on their phone. So some of the things that we can't change, we're targets, we're sitting ducks basically for bad influences. So, I mean, that's too much to include in that, but those are types of things that we need to, hint at.
I think those points are well taken. In other words, as we look at why there are things in which we have control over, we need to identify those things that are controllable
Mhm.
by external forces, and then
Mhm.
those things that are controllable by each and every one of us as
Mhm.
individuals. Some things are.
That's
Some
right.
decisions are, and some decisions are made around us. So
Yeah,
Is
I'm
it-
thinking, oh, I'm sorry.
no,
I'm
you go
sorry.
ahead.
Mhm. The number one why I think is Rachel hit it on the head is institutional racism. Whether or not we can control it or change it, it should at least be our objective to try to change it.
Mhm.
And if that's one of the uncontrollable things, it still is the number one reason for us being here in the first place.
Mm-hmm. Mm-hmm. And
Yeah, and I would also say that while it's obviously food related, I think a lot of things come back to poverty and cost. You take just a simple juice, and instead of having orange juice, you have juice that's got high fructose corn syrup in it, which we now know is so much worse for you, but it's cheap. It's
Right.
less expensive. So, and everything builds upon that. The
Right.
inexpensive food that is affordable and is available at the corner store and beyond is, we now know, is so much worse for you. And so it breeds itself
Mhm.
into those preventable diseases that you have to live with for longer. And then I think that the institutional racism of not being treated fairly when you do go for medical care, and maybe there's even I won't say a social norm, but a routine or a pattern or a family lifestyle of going to the doctor less often. That's not common, those kinds of things. And so using the healthcare system in a different capacity instead of in a preventive nature, using the ER as when you're sick, and is that because that's what's affordable? I mean, all of those things are also tied together.
Mhm.
I'm
Even-
hearing,
Oh,
I'm
I'm
sorry.
sorry.
no, you go ahead. I'm good.
Well, the only other thing I was going to add was, and even I tend to sway away from individual behavior because the system level things actually influence individual behavior, I find, in a lot of ways. And we have found a lot of evidence, just sticking to the food insecurity piece, that just implementing food prescription programs where you're giving access and relationship-based coaching with a program like that, just the end result is improvement in health outcomes. It's just a
Yeah.
change in the system to
Yeah.
allow for access and education, but it can't be one person at a time. It's like a change in like the system. So I think the downstream effects is individual change, but I don't think individual change equals system change.
Good, good.
I agree.
And I was
But
about,
I do think there's a component of attacking it from both sides can be a better way to see that those benefits faster. Otherwise, I think if you just start from the systems, it's going to take longer to have that effect on an individual level.
yeah, I was thinking the same thing as we talked about choice, because otherwise we get into blaming. But individual choice is I think is a component. But then there's the cost of the choice, I heard.
Yeah.
And then there are the options of choice.
Yeah.
And so those two things are quite critical. I may be an individual have the power to make an individual or personal choice, but what's the cost of my choice and what are my
Yeah.
choice options, which is what you are talking about.
Mhm, mhm.
And you
I-
have to be aware of the choices before you can even know to make them.
That's right. That's right. That's right.
Which is-
Options.
Which is going,
Options.
which is going back to a lot of what Rachel, you were talking about, is providing those kinds of opportunities so people can make the right choices,
Mhm.
whatever right means.
Right. The healthy.
Or
Right.
whatever they
Yep.
think is best for them and their family. Yeah, exactly.
So if we had to say, what's the root cause of our problem? Let's go through. Have we begun to address some of those whys? And if someone can help me here in being able to put those things into the chat as we talk about whys. We've talked about some of those, but
So
We
would
have-
the center be the one, or would center be five in terms of the basic cost, or cost, or the beginning of the cost? Which way are we going with the middle or the outside ring?
I would say that beginning at the center and going out to the perimeter. Some people look at 5 whys in terms of the outside going in. Would we agree that what we'll do for our discussion is to begin, let's begin with the center of why and come out to the perimeter. You might come back and say, and no, I think we should begin at the perimeter and let the root cause be in the center. Talk to me as to which is easiest for us to think about. Anybody? Let's reach a consensus on it. I think that's an important question as to where we start.
We know that poverty and finances, I think somebody mentioned that poverty and finances is a big deal. Options, institutional racism, and options options and opportunities. I think if we start pulling one of those out to begin with, there's always been that the financial component that is, eliminated you from an opportunity to have options and make choices and be in a situation where you can make better choices. So I think that may be the first thing, is that just financially, the community is already behind the 8 ball, so to speak. So I think if we begin there.
Are we targeting our problem? The problem statement is, and I'm not asking you to defend what you said, but
Mhm.
we die at an earlier age and at a higher rate of preventable diseases. We live with more chronic diseases, reducing our quality of life. Now the
Mhm.
question was, if that's the root problem, our analysis is why.
Again, I say institutional racism is the root cause for all of these things. That's why we don't earn as much money. That's why we're poor, and that's why we don't have access to as much health care. I mean, it's all traditional.
Mhm.
So I still maintain that institutional racism is the root cause of these problems, and then there are multiple results of that.
And if we accept that, and we do as a premise, why?
Well, I may be the most, I may have put the most fire under my statement, but I stated in the chat that I believe it's the dominant exploiting systems of the United States, which are largely reliant on anti-Black racism, colonialism, white supremacy, and capitalism that
Wow.
takes away Black autonomy and tools to live healthy lives.
Wow.
That is my suggestion.
I hope you put that in the chat, Rachel.
I did.
Yes.
That was
Yes.
a lot.
It's
Because-
a lot.
Because it sounded great, and I won't remember
Yes.
all of it. It sounded great.
Yes.
I like it.
I like it too.
Is there a consensus around that statement? And then the next thing would be, why? Let's dig deep in that. Why is that? We haven't gotten to the what yet or how, but why?
What? Why what? I'm sorry. Why Is there
Why?
institutional racism? Or why is what?
A culmination of what Rachel talked about. Why is that? Why?
Well,
The root cause of, what's the root cause of that? Or is there a need to explain the root cause of that? Is there another problem statement within the problem statement that we need to get at the root cause of?
You know, I often ask myself that question actually. And I, you wonder like, why can't we pull out of that? Right? Like,
Mhm,
why
mhm,
can't America pull out of that? What's the root that keeps driving that? Is
mhm.
it greed? Is it hate? Is it like, what is it? And I don't know the answer to that. I don't know the underlying. Is it our broken humanness? Like, I don't know. Like how
All of it, all of
Mhm,
that, I think.
mhm,
But I
mhm.
think the main thing, the main driver, and this is Latrina, I'm finally on, you guys. None of my devices would work, and finally I got one on. But I think it starts with greed and having to maintain that. It just has to be. I mean, because if you have institutions that have been propped up due to racism, systemic racism, and in order to keep that going, either you change drastically, and it comes with a change in the way we think about fellow human beings, and that humanism, I think is lacking. It is lacking in all aspects of our society.
I think the root cause is started with the institution of slavery. The institution of slavery.
Colonialism, probably, yeah.
Yes, because
probably colonizing, because the colonizing kind of changed people's belief systems.
Well, they tried to colonize, but it never did. Anyway, so many of our political structure, our financial structure, started with slavery, and our efforts to maintain slavery and still have live up to our dream of being a free society. And so there were compromises made that led to institutionalized systems that exist today. And again, I understand why what we're all saying about why can't we get rid of these systems. It's a deep, deep problem that has to go all the way back to how they started and whether or not it can we restructure the way that the Congress and the Senate is right now structured. It needs a whole restructuring. I don't want to preach on this, so yeah. But if we look at the Reconstruction era, there was a whole that little 7 or 8 years when right after slavery, the Emancipation Proclamation, right after that whole little time period, there was another kind of government structure that enabled us to kind of live up to the promises of America. And then when that was struck down, we started a whole new way of doing things.
Yeah.
And even though I understand thoroughly the process of trying to reach consensus on this, it is always challenging to look at the why and then want to immediately think, well, what do I have control over in the what? And I know we haven't gotten there yet, but I just wanted to give a voice to that can be challenging, is to think about why and then how.
Well, I think you can hold, and I put some tips or thoughts or brainstorming ideas in here. I think you can hold institutions accountable. Like, I think the Black community has enough power, and especially in this moment, to promote accountability. So if institutions like mine, and of course, they're starting to do, racial equity trainings, and they're starting to think about transforming white privilege. Well, if they're doing that internally, well, here's a moment where external voices and internal voices could intersect to actually do system changes. And those do have impact. You might not be able to change the government, but I think you could change. I mean, I think eventually could, but I think like right in this moment, there's an opportunity where institutions are looking hard at themselves. And then, especially here in Winston, and then there's the community looking hard at these, you know, these big gaps. And maybe at this moment, there's a chance to influence real change and to give concrete, you know, things. And before I stop talking, one other thought I had was, and I do not want to speak for you as a Black person, but as I think about this and I think about Harriet Washington's book, you know, as the very first interaction that Black people in America had with a physician or a person in healthcare was as a slave, and that physician's job was to assess their value so that they could be worked as hard as possible for the slave owner. So their relationship was not for the betterment of the person they were caring for, it was for their monetary value. And so I think on the flip side, that trust has never been there. Like it's never been there between healthcare and the Black community, as far as I know. And like just from my perspective, as I learn more about history.
Excellent point. Excellent point.
Yeah.
Katrina, our worthy group leader, I turn it to you to help us in being able to move from the problem statement of the why. Have we dug deep enough? Have we dug deep enough in the why of our problems?
Yeah, and I think I missed too much of it to really
Okay.
get it down.
I'm going back 3 or 4 slides because I think it's important that I put that in there. Y'all help me to go back to where it was, right? Hold on, stay with me. There it is. Okay.
That's it.
I took the statement that you sent to me, Latrina, and actually Cheryl reminded me of the statement as well. So this is the problem statement that we addressed. Now we've begun to dig deep into some of the whys, the root causes of the problem, and talking about why.
Okay.
Okay.
Okay. The whys.
Right.
So systemic racism, and then what Rachel said, the historical lack of trust
And in
with
English,
physicians.
I'm sorry, go ahead.
With physicians. What else was stated? And I'd like you to help me kind of just document this, Anne, this time.
And actually, the team has done well. Everything has gone into the chat.
Okay, very good.
So at least we won't have to go back and regurgitate that in our heads. So
Okay.
that would be helpful. But this is the process of why. Are we
Right.
fully comfortable, if that's a word I might use, are we fully comfortable that we've asked enough to dig deep about why, the answer to the whys of our problem statement? Again, I vacillate in my head, the why and the how, so help me to stay in place, because even as I teach this, it's still challenging for me to move from why to how.
Maybe
So-
we can,
Go ahead.
the only other thing I was going to suggest was for the problem statement, and I'll put this in a chat, maybe also noting that we don't just, or that Black people don't just die earlier, but infants die at a higher rate.
Okay.
So it's not just early death due to racism. And then I forgot my second point, but I think it was something to do with accountability, like lack of local institutional accountability to Black communities, something along that line.
Mhm.
That's the why. Okay.
Well, no, just part of it. I think
Part of the problem
Yeah.
or part of the why. Okay.
And I think you opened the door as well to the issue of trust, not only trust, but current trust with there being data to show that there are often, not often, but sometimes there is disparity in how African Americans are treated in healthcare as opposed to other entities. So that's,
Yeah.
Yeah, and individual responsibility ought to be a part of that. Why somebody did say that, but I don't know if we captured that, because even though the root cause may be racism, we still have individual responsibility to try to address some of these issues.
mhm.
Yes, okay.
I think somebody mentioned having a two-prong attack with that, having a system from the top down and then the individuals to come together. And it's going to take both components. So it's a system and an individual responsibility in that when it comes to, that could be part of the why though. I mean, the how.
And
Oh,
And
okay, could be.
I just want to throw something out there too. And when we say individual, Lee, culturally, and we've probably gotten away from this a lot in the Black culture, but we were more community and family oriented before. So would we say family?
Somebody did mention that.
Yes, early on we did. Mhm.
Okay, good. All right.
Absolutely. Excellent point.
Mhm.
Yeah.
And costs. I think we talked about costs
Yeah.
and options. You know,
Okay.
food options, cost, well, you know, just options for whether it's
For
healthcare
healthcare.
or food choices. Mhm.
So we're not that badly, and I think that we've done well in terms of what you see here, defining the problem. Why is it happening? We've explored lots of whys, and why is that? Why is that? Why is that? I have heard the culmination of individual choice as well as the cost of that choice and the options of that
Mhm.
choice.
Mhm.
We talked about earlier.
Mhm. Mhm.
Move this out of the way. Root cause.
Well, when you put that one up, Rachel's statements is right all in that blue right there.
Yes, it
It's-
is.
Yeah, it
It's
is.
great.
Yeah,
We
it's
can
right
get that
there.
out. We can get that out for the recording for sure.
Yeah.
'Cause it was
Mhm.
very succinct.
Yeah.
Mhm.
Mhm.
Vision. As we talked about the problem, we looked at the why. What will be different as a result of the work of this group with the community? We've come with a barrage of suggestions but so what will be different as a result of this group or what we do, given everything we've talked about in the next year?
Everybody in the community would have health insurance.
Mhm. There you go. That part.
And please add that in the chat if you would.
That is aspirational.
Right.
I don't mean to laugh. That's a fight that I've picked up my whole life.
Shorthand.
I guess one thing too, though, that so I think I had mentioned that I do some research, and one thing that I've been doing research on is people who have Medicaid and their experiences with Medicaid and their access and versus uninsured. And one thing that has kept coming up, and when I did some research, this is coming up in other academic medical centers, and there are some proposed solutions actually by there's a group called White Coats for Black Lives. And one thing that is common is that people who do not have health insurance and people who have Medicaid only are typically seen by residents or medical students, while people who have private insurance tend to be seen by attendings or by a primary care provider that's stable. And I think that inconsistency of providers not only causes lack of satisfaction, but it's a very relationship, it's a relationship barrier. So if you're already worried about trust, it's already, so I think well, I had mentioned this before, I think in the chat, but holding like whatever you choose for the health, I think you go to the health system like a list of 5 things. Like, we believe you should do 1, 2, 3, 4, and 5. And this is what we think you should operationalize. I mean, I know I'm,
Mhm.
don't tell way.
That's actually really good. I think
Mhm.
having a solution and just, bullet pointing 5 things,
Mhm.
that's very important. Those are very simple ways to get to the individual advocacy piece.
Right. And it
For
doesn't
sure.
fix the whole problem, but at least you're getting to like some actionable items.
Right. Doable things that we can actually see through. Okay.
You just took the word out of my mouth, Latrina, because I was thinking about advocacy or the lack thereof often in individuals who feel that they don't have power or don't know the questions to ask, the lack of advocacy, external advocacy, and also self-advocacy. I think is something that often is lacking. You can go with people to the doctor, and if they take someone who can help to inquire, or a healthcare professional. So self-advocacy as well as having a support system of advocacy.
Rachel, I have a question about the white coats for Black Lives. How long has that been in place?
Oh, let me see how many years they've been doing reports. Not very long. I think 20.
Where are they? From where? What
It's
region?
national. It's national.
National?
Yeah, here, I'll pull it here. It was, 2014 is when it started. I'll put the link in there so that you can look at it.
So are they just research? Is it just research?
No, it's healthcare providers who are passionate about health equity and racial equity.
Okay. Okay.
Mhm. And they did a few reports the last 3 years that have very specific recommendations for health centers and health systems to integrate for equity.
Okay, I got that. Thank you.
Mhm.
Oh, Lord,
Mhm.
what am I doing? Okay.
Have we addressed this well, Latrina?
No.
Good
What we
point.
want to see next year? No. Like, what is a short-term objective? One of them is, the list of 5 things when you go to the doctor. I think that's a short-term objective. And then maybe another one when one thing that's not addressed is, the connection between mental and physical health and vice versa, because they impact each other. And I see it more now during the questionnaires. Even when I go to the doctor, they ask you about that.
Mhm.
But my question is, do they really look at it?
Right.
Or
Right.
does it just go in the file?
Check the box. Mhm.
Right.
Mhm.
Are you experiencing domestic violence, which is also a health issue because it goes back to roots of, inequity and, men not being, necessarily in the families as much as for whatever reason. That's a whole nother, that's a whole nother story. But I think doing this for mental health is important as well, because there is a stigma.
Mhm.
Mhm.
Definitely.
So I guess if we go back to the problem and what we would want next year, so the infant mortality, what
Yeah.
would we want to see in regards to infant mortality within the year or by next year?
Well, how can you, I don't want to use the word guarantee, but encourage expectant mothers to get that prenatal care and that prenatal, the food. I mean, I think it's as important to see the doctor as it is to eat the right foods
Right.
while they're pregnant. So, and to be, you just mentioned domestic violence, to be in a safe environment while you're pregnant. So those 3 things impact infant mortality.
That's true.
Well, one thing I had put in there earlier was establishing some sort of accountability measure, like on equity scorecards, and infant mortality is definitely a big one, and prenatal maternal death, I think would be another indication of whether or not you're impacting, positively impacting prenatal care for Black women. I know that I know April Miller, who was on here earlier, she's a OBGYN, not today, but the last couple weeks ago. She is actively involved in some projects around Black maternal health. And it could be helpful to reach back out to her to say, okay, what should we be asking, like the health
Right.
system or healthcare leaders to be integrating and then providing like accountable measures on each year, like what, or quarterly, like what should we be asking? Because here's in my head, I feel like the health system should have to come to the Black community and say, listen, this is what we have done for what you're asking us to do. And that should be a demand.
Wait, you know what? When you were saying doing an accountability scorecard, would a viable tool be to develop an app for, well, not for the system, but we're talking about our mothers, our expectant mothers. And I worked with one of the Kate B. Reynolds initiatives. Was it Kate B. Reynolds? I can't remember. Some years ago, where I worked in early education, so I was a mental health consultant for early education. And I had a conversation with her, Marnie Eisner, if anybody knows her, and how they kind of track the mothers. I think they were trying to start doing that and giving some incentive. And when we think about how the brain operates, incentivizing things and making things easily accessible, I think is helpful. It's something helpful to look at. And so if you have an app that, and I know that's probably reaching, but we have an app for everything else. I have an app to track my sleep, and I use it, and it helps.
It does, because it'll encourage them to eat correctly, to visit your doctor, see if you walked enough today, or whatever it is that's needed. That's going to increase the likelihood of a safe pregnancy and a safe birth and delivery. So I think that's excellent. A scorecard being an app, because young moms, they're on their phones, on Facebook, you see somewhere all the time,
and it'll remind you. Have you eaten your so-and-so today?
Right.
Or something that's fun, engaging.
Right.
And if we're talking about someone spending dollars to make some changes, that's where some dollars can be spent.
And I think those same incentives would be good for just for medical. Have you had, even if for men? Have you had your annual checkup screening for prostate cancer, or do you know your blood pressure numbers for everybody? Do you know your risk factors for whatever? You get, like you said, these incentives. If you hit all these goals and answering this, maybe you qualify for something. If you've answered these questions, if you've seen your healthcare provider this quarter, have you had your flu shot? I think that, that's wonderful to be able to use that kind of technology as a scorecard and make the healthcare system accountable too, because you got to go to somebody to get, to be seen, to get credit for that score or what have you.
That sounds like an interesting project for a group of college students to work with the researcher.
Techies.
And identifying funding to do that. That's an excellent thought, Latrina.
Excellent.
Yeah,
Excellent.
that's culturally, enticing.
And right, I think it's a great idea. And insurance companies already have systems in place where they give rewards for people to do certain things.
That's right.
And we could kind of mimic some of their work and even perhaps get some dollars, because in the end, those people, the people who adhere to the various requests to do things get actual dollars. First, the points are collected and those points are translated in dollars, and then they can take those dollars and buy gift cards. So perhaps we can mimic some of their
Yeah,
questions
maybe
and
Amazon
stuff.
can give some gift card.
Right.
right.
They have, yep. So we got that together. And let me just say that I didn't realize we were looking for a vision in the short term for the next year. So for healthcare insurance, and I'll put it in the chat, we should target to increase the number of people within the Black community that have health insurance by X%. So I'll put that in the chat.
Good, good, excellent.
Anybody want to throw a percentage number out there?
25%?
Okay.
And I think for those and for those who cannot switch over or do not have health insurance, I think just making sure that there's some sort of like report card where the hospital's saying that, you know, that people of color are seeing attendings as frequently as white people are.
Yeah.
Like,
Okay.
that's a good
Okay.
metric. Like it.
So you're saying
Yeah.
uninsured and Medicaid recipients seeing attendings just as much, having it. Okay.
Well,
That'll go over.
that's
I wish to be a fly on the
it's
wall.
really a dream.
It's a good one.
Well, I mean, it's just a report.
Yeah, it's in your face. It'll make them think. It'll make them realize that, okay, yeah, we have been doing that. I mean, whether they
It's a
admit it out loud or
report.
not.
Mhm.
Yeah.
Sometimes we're not asking them to do anything. We're just asking them to report at this point, right, Rachel? Is that what you're saying? Or are you asking
Yeah,
for?
I think they should report just current numbers and then how they plan to improve that. Because I
Okay.
know it's proportionate. I don't know that they've looked at their own internal numbers, but I know that they're able to. And
Okay.
and then, you know, and like I said, I work for this institution, but I'm very vocal and they know how I feel about these things. So I, you know, it won't be a surprise. But I think that, you know, making that publicly available, like holding that measure as an accountable measure, I think is important. It's a good first step for them.
Yeah, that's good.
Is there any way that, you know, this is just out there, we were talking about advocacy, self-advocacy, and the other advocacy, I can't remember what it was, but sometimes there's not self-advocacy because they don't, you know, the patients don't necessarily know what their bill of rights, what their patient rights are. And so if that information is public somewhere where everybody can know what your rights are as a patient, you know, we know supposedly what our rights are as citizens, whether they're given or not, whether, you know, exercise or not. But, you know, do people necessarily know what their rights are when you go into a doctor's office or when you go into a hospital or what have you? That you have a right to know the results of your tests, or have the right to have somebody else to explain it to you, have the right to have it explained to you in a way that you can understand, you know, what's going on with you. If you don't know your rights, you don't necessarily know to ask for certain things. So, I mean, like what Rachel said, I didn't even know about that, about, you know, white coats and all that, and attendings versus residents and all that. I mean, that just blows my mind to even hear that. So, you know, patients should know that, you know, I need to see an attendant. Know that word. Know that you can ask for an attending physician.
Yeah, you're supposed to have the patient rights are posted, but they're always posted innocuously in the hallway when you ask them and you never pay attention to them.
You're right.
Or like knows that they're there. And they're not, I would say that they're in plain English language, but they're so overarching in general that it doesn't really say that specifically, for example. And
Wow.
so you're right. I mean, it's legally it's there and has to be there, but
Wow.
it's not emphasized. And I'm a healthcare provider, so I know that.
Wow.
Right. Yeah. And as a mental health provider, we have them and they're posted. Yeah, but do people really know?
Right.
No. No. So how would we, so if we're looking at a vision and if we're looking at So we're still looking at a year. We're gonna look at 5 to 10 years in just a second. But
When the only,
you know, and again, you know, these kind of things could be on an app where, you know how I have an app, it's a meditation app. It's a monk that sends it. He'll send every day, he'll send this quote or whatever. And I read it, and some of them just really stand out to me. So it's something like that could just be integrated. I don't know if that could be done in a year, but it can definitely get started for those important factors that we know negatively impact patients in our community. Then those things could just be done, because you know, a piece of paper is not enough. You know, it just has to be something that, you know, is repeated. Even on the Alexa thing, I don't know if anybody has Alexa with the screens. It'll put up little technology is just
Alexa show.
amazing. Yeah, it'll show you things. I'm like, oh, I didn't know that. Interesting. You know, so they know it.
Right.
So just utilizing what's already out there for all of these types of things, I think.
you know, Latrina, the My Wake Health, and I work at Wake, so, but I know Novant has the same thing. They already have an app. So all they would have to do is push that.
But it's for their patients, it's not for everybody.
Yeah, I guess I was thinking that you could ask them for, because most patients are taken care of by either Novant or Wake in the city. And so I was just saying that maybe those rights could be broken down more and then pushed out to patients before they go to their visits. So
that would be good.
It's in a different type of language. I don't know. I'm just brainstorming, but
yeah, that's good. That would touch part of the population.
And I'm a believer in success leaves clues. I wonder if there is such an app that at least partially exists in the world, in our world, that may be modified, or again, it could be a project that we could convene with an institution to explore that possibility.
Right. I like the
develop
fact use something that's already there, just expand it, right?
If it's out there and it needs to be adjusted, then I think it's a wonderful thought.
Well, you know, if you have a Fit Tracker, a Fitbit, or Apple Watch, or whatever, they have so many of those monitors on them, and they now are tied to everything. It'll come up on your whatever, I mean, your phone, whatever. And those types of things can be, you know, modified or whatever, like you were saying, to fit what, you know, what we're trying to see, you know, whatever goals we're trying to get people to reach personally on that individual accountability level. You know, it's in your phone. If you don't have a Fitbit, if you don't have an Apple thingy, it's in your phone somewhere where you can, you know, like Trina was saying, she has a meditation app. I think I have a yoga app that, you know, that I sit down and do sometimes. So those things are actually already there, available in our phones. We don't necessarily activate them or what have you, but they're actually kind of there. If we just draw attention to that,
right,
you know, to make people use them.
So we need an outreach campaign that informs people about some of the things that we are talking about now. Put some information into their hands.
So that would be a short-term goal.
Yeah, sure.
Okay.
We can certainly do that.
And explore what already exists, and as well as explore possibilities of partnerships to develop what doesn't exist.
Right. And I don't know where this fits in. I kind of lost our space a little bit, but one of the things that I often hear from the people I work with is that they would like to go to African-American primary care provider. And there's almost impossible to identify who is a Black, what the races are of the primary care providers. Plus, there are very few African Americans that are primary care providers. So maybe one of our objectives is to have the list would be great, and also have the hospitals support bringing in the healthcare systems, Novant and Wake Forest especially, bringing in more African American primary care providers.
Yeah, that's a
Hiring
hot
them.
issue, Sandy. That's a hot issue right now inside
Yeah.
of the health systems, because the training of Black physicians, the proportion is still so low. And
Right.
so I think holding health systems accountable for what they're actually doing to increase, people of color in their training and their success. I think that that's a great point. And I actually don't think that there is a publicly accessible list of Black providers. And then that could be physicians, nurse practitioners, physician assistants. Like, I don't believe that there's like a publicly available list. That could be a very easy thing, for the health systems to immediately do. Because I know that there's a PA who's been at Winston East in the pediatrics department for like 20 years. And, he's like integrated there and provides excellent care. And so I just didn't want to, suggest that just because they're not physicians, they're not excellent.
Oh, right.
There's some really good Black providers who may not be a physician.
Absolutely.
Yes, that's a great point. But I would also like to see more physicians as well. But that's an excellent point, that there are good other kinds of providers.
I mean, I am a nurse practitioner after all.
Oh, nurse practitioners are wonderful. I love and respect you guys.
Yeah, some of my best care has been with NPs and PAs, actually.
I'm proud.
Their bedside manner tends to be a little better.
I'm proud to say that my daughter is about to take her NP exam.
Oh, wow, congrats.
And I can't wait until that happens.
Congratulations.
Success.
Thank you so much. I'm proud of her.
So with going back to, is it you, Sandra, going back to the recruitment process? So I guess that would be going back to what Rachel said as well. How many med students that are Black are actually, accepted or in the local programs, medical school programs.
And we might have to reach
I
out
know
a
it's
little
a
further.
rigorous. Yeah, I know it's a rigorous.
I've added in the chat that to create a directory of African-American healthcare providers.
And if you Google it, you do have a directory that comes up, but they're very limited, and in Winston-Salem area, it's very, very limited.
And
is everybody on the directory?
Right.
What that directory is from, yeah.
And if they're not, how do we create a directory that includes them in this area and distribute that directory? At least it'll be a provision for people who might be interested in that. Yeah.
Mm-hmm.
And I think going back to the students, I mean, you could just at the very least have them publish their data on what are the student demographics, where are the disparities, and why are those disparities there, and how are they addressing them? So you could at least get a baseline from institutions.
Mm-hmm.
Yeah, that's a great idea. The institutions, I guess, because of HIPAA laws, cannot tell you who the race of the people that they have on staff.
Really?
So they won't. They won't tell you who's Black and who's not.
I did not know that. Okay.
Mm-hmm.
So I guess maybe can we say in 5 to 10 years, we want to see an increase in Black providers?
Yes.
In Fife County?
Mm-hmm.
Yes. Yes.
NPs, PAs, MDs.
Right. And especially the reason that am emphasizing primary care providers that are MDs is because when you get Obamacare, you have to list an MD as a primary care provider.
Oh, and you wouldn't know who in their practice would be an NP or a PA.
Right, exactly.
Huh. Yeah, that is a challenge.
Yes,
Not
it
that I
is.
knew that, Sandy.
I'm sorry.
I said, I'm not sure that I knew that you couldn't list your PA or NP as a.
Mm-mm. No, you've got to list, and it's not. Yeah, it is Obamacare. I know that you have to list your a medical doctor for Medicare, or your Medicare and Medicare Advantage products, but you don't have to list your primary care provider for Obamacare, but you must have one. And I guess you have to tell the insurance companies. You don't have to list it on your application, but on your insurance companies, they will ask you who is your primary care provider, and it cannot be. And it has to be a medical doctor.
I think you're right. I think because I've had people do it and you have to search to see because the policies are so different and so you do. And you have no idea unless you try to look them up to find out, what their nationality or race is, right?
Exactly.
Wake does very well of putting pictures up of all of their providers. Now is it Wake or Novant? Probably
Novant.
My picture's up as a primary.
Okay, so it's both. Okay.
Yeah. And I'm a Medicare provider, so I think I'm looking myself up on Medicare to see if it lists me as like a physician or how, because I am a listed provider under Medicare and I'm a primary care provider. So I don't know if they're calling doctors all of the above, or if like I should be listed as a primary care provider. So I don't know that.
Where is your photo on Wake Forest's website?
Let me Google myself and I'll put it on there.
Okay.
Rachel, you very good with that tech.
She is. I'm telling you. I can take notes.
Okay, here's me.
And this is the Wake Forest website?
Yes.
Ah,
okay.
Nice picture.
Oh, thank you. That was about 10 years ago.
Oh, you look the same.
My faculty.
Yeah, it says adult provider. Mm-hmm.
Yeah. So
you need a rating. Look at all rating. I wonder what that's about.
Oh yeah, that's actually because our hospital system does not ask for patients to fill out surveys related to care if you're cared for by a physician assistant or a nurse practitioner. Just started doing it, but that was actually a disparity within our own system. Just FYI. So
okay.
Wow.
I'm still trying to get to it. Okay.
Left, Trina.
Oh, sorry. I'm reading about Rachel over here. I was not even present. I was reading.
Funny.
Okay, so all right, so we got a 5 to 10 year. We have one 5 to 10 year goal. I guess we can add one for infant mortality. So we can have two. That's if that's. I like to speak in positives instead of decrease. I like to, but anyway, however you guys want to say it. Go ahead, Cheryl.
I was just saying better food options and better food choices. I mean, you can get a burger and some chicken and some fries. I mean, there's a restaurant supposedly that specializes just in French fries on 25th Street. I haven't been to it, but
I've heard of it. Yeah.
Yeah. I mean, any kind of French fry you want covered with everything. But is there a place where you can get a fresh salad with some grilled chicken or something or some?
No. So there's
Yeah,
McDonald's, Bojangles, Popeyes, that restaurant. So you can get chicken,
Yeah.
chicken, more chicken, and some French fries.
right.
Right, better food. Yeah, better food
Food,
options.
better food options. Yeah, just better food options, just cleaner food options. I mean, I know Whole Foods is not gonna come over here and, we may not get a Cava or whatever that restaurant is on Stratford. But,
We can ask
That's-
Popeye to put some salads on their menu. Can we do that?
I've got a great idea. I think this work group should create a franchise for that.
Oh,
wow, wow,
okay. Ann.
wow.
Because the franchises are the ones who are bringing those restaurant that you're talking about, all those are franchises. And so
Mhm.
a franchise owner decides, yeah, I'll put my Popeyes there. And Starbucks is not doing that,
Right,
as an example,
right.
or Popeyes.
Oh, so, okay, so it's like the chicken before the egg. Okay, so they gotta wanna, we gotta wanna.
It has to be a better option. I mean, it has to be a more favorable. Well, we talked about the fact that that a clean salad is much more expensive than
Yes,
a
so
Whopper.
cost, yes, yes, okay,
Yeah.
there you go.
Yeah,
Okay,
yeah,
that would be a good work group, because we do have the food insecurity group.
yeah.
So they're working on that. So maybe that's something we can push out to them,
Okay,
because they have
That's
a
right.
very, very passionate group leader. He is on it all day, every day.
Yeah. And with all the urban farms in town now, there certainly will be someone who is exploring how would an urban farm become a distributor, or if you will, a provider of a restaurant, like what
Mhm,
you're describing in East Winston. With all
mhm.
the urban farms, and all this growth, there has to be some way to explore that possibility.
Right, well, there are multiple small businesses that are, have food trucks that are going into various communities to try to give away or sell healthy food items. And they're expanding all the time. I just was I guess you're a rate or a judge or something for American Heart Association grant program, and there were like 10 different food service folk who were requesting freezer money to buy freezers so that they could have more frozen items to take into their communities. And
Excellent.
and there are many food banks that churches are running. They're also trying to get money so that they can expand their space, buy freezers again, so that they can offer greater variety of healthy frozen foods. And healthy and frozen might be, what do you call it or not?
And maybe building off of that is, I know, like, you think of Share, right? I know there could be, there's been a lot of conversations around the health system's responsibility to support, there's that 10% recommendation that 10% of the funds that are spent on food be spent on local food in North Carolina. And I don't know that Baptist does that, but you could potentially ask that, the hospital system or systems show and I think I put this in there too, but the Black vendors, but maybe specifically Black food vendors and farmers that they help support, and maybe you could just ask for, I don't know. I'm just trying to brainstorm.
Like kind of the supplement.
Yeah, like how are they, like what are they buying from Black farmers? I actually have a meeting with the owner of Produce Box in a couple weeks, because I was chair of the PTRC Food Council, so I know Michael Banner really well. And then we were over that 12 county food assessment, and one of the recommendations was that more money be spent on local foods by big corporations. And of course, the cold storage thing came up too, which I'm glad they're actually doing something about. But but could you integrate, like, and Produce Box does a really good job of working with local farmers, but could you make sure that if they're going to do something in your area, that they're working with the local farmers in the area, and then those are then paid by the hospital system? Like, could there be like an economy around that, you know,
Okay.
that's by the health system? I don't know. This is really just me, you know.
Yeah.
That's
Good
what we
thinking.
brainstorm.
Yeah.
Excellent thinking. Yeah, excellent thinking.
Or do they put money into Share? You know, Share's a black led co-op. They've been trying to get money for years, you know, to build this store. They're finally getting it built. You know, is there a way for the health systems to show that they're supporting black led initiatives to address food insecurity by putting money into Share?
Yeah,
Right.
yeah.
Interesting.
Yeah, food is, as far as health and wellness, yes, food is vital.
That way it could maybe bring down that barrier of costs. You know,
Right, that's what I'm thinking. Uh-huh.
yeah.
Right, because it subsidizes the cost of the food, you know, if they're putting money toward it. So
Okay.
that local community members could then afford these locally grown produce items and not have to spend $5 per tomato or whatever, you know, like it could be.
Right.
Then the
Right.
farmers get fair price for their items, you know, so it makes it worth their time. Because that's kind of the difficulty is, you know, the local farmers want to sell to the communities that they're from, but then they can't afford to down price their items because they
Mhm.
already don't make money. So it's an economic problem.
Okay, I like
Well,
that.
one of the things, one of the organizations that was applying for the AHA grant was going to use it to reduce the cost of their items, so that they would take 10% or 20% of their price and pay it themselves from the grant, so that the people could afford it.
Mm.
So that was a thought.
We have about 8.5 minutes left, and we're on slide 19. But Latrina, what's your druther? Mhm.
I think we've captured a lot of this, most of this. Creating the vision. Yeah, I'm going to try to put something together to kind of capture all of what we talked about. They don't want a step-by-step plan. We want a vision. And I think we can pull something out of what we talked about. It's just, okay, so 5 or 10 years down the line is what we're kind of talking about. So, I mean, food definitely, food options, that would definitely be more of a, I'm not going to say long-term, because 5 years is no time, but, you know, to have really sustainable food systems in the community is very important. So sustainable food systems, we talked about having more providers of color for sure. We talked about having an app for to reduce
Scorecard.
The scorecards and infant mortality.
Mhm.
And then for just preventable disease, just, as a whole.
To
And
enhance.
then, yes. And then we also talked about increasing insurance coverage by 25%.
Mhm.
Is that 5 to 10 years? Or are we looking at 1 year? 5?
That was 1 year.
That was
Kim.
one. Okay.
Mhm. Yeah,
Mhm.
is it possible to expand Medicaid in North Carolina?
5 to 10 years.
Well,
Yeah, I don't
one
know if we have influence to do that.
Well, so I put that in the chat. I said, if you're going for single payer, which I think that's what you're alluding to,
Right.
then what I suggested was that the medical school and hospital support local, state, and national efforts to establish a single payer healthcare system via lobbying efforts. And then a formal position statement and hosting of supportive organizations and events. So like evidence that these organizations are lobbying on behalf of that. And I believe that they are, but just showing that and evidence of it within the community. Because I believe that hospital systems feel the same way that local community members do about that.
Okay.
Yeah, that's very well put. But it wasn't a single payer system that I was referring to. I was just talking about expanding the Medicaid system, as many states have done, but not North Carolina. And
Okay. I'm going to include both of those, Sandy. I'm
Okay.
going to definitely include that. You're right, because yeah, most of the southern states didn't.
Yeah, I'm kind of sad because Biden's social reform policy had that in there and then
it did.
out.
Yeah.
Yeah. Strike things down. Is there anything else? Let me close the chat so I can see. And it talks about realistically achieving. So we'll look at what's realistic. How much time do we have, Ann? We don't have much time, I don't think.
We probably have a good 5 minutes. Yeah, a good 5.
Let's see.
Creating a
About
picture of the community.
7 more minutes.
We probably should be done at about 7:59.
What will happen when we are successful? So what if we can use our imaginations, what would East Winston look like in regards to health and wellness?
I think if I had a dream about, especially the health insurance piece of it, that there will be, right now, I think 10% of the overall population in North Carolina does not have health insurance, but that's disproportionately affecting Black people. And then of course, Hispanic Latinos, about 50% of them do not have health insurance in our state. So bringing that closer to the 10%, for Black and Latinos, but I know we're specifically focusing on Black populations for this, but just if you're going to say what's a success measure, getting it closer to that, white measure of 10%, if you could move the needle.
Okay.
Yeah.
So the 10% uninsured, that would be success. 10% or less. Okay. So that would mean we're looking at 90% of people have coverage and are actively receiving medical care. There are people who have coverage that really don't seek medical care. So that's the overall vision that we want to see. Anything else? Anybody else imagining?
I imagine that there are fewer children walking around with, what do you call those little things, inhalers?
Yeah.
I have nieces that, they're all on inhalers or eczema. I don't know why eczema is so big now. I mean, they all have eczema or an inhaler.
Yeah, Cheryl, I think it's like you said, it's the food. It's gotta be.
And and the air pollution, the asthma rates in Black children are 800% higher than white children.
Yeah, a little kid died of asthma, a bad asthma attack, and my heart just.
Yeah.
800%.
800%.
Wow, that's a lot. I wonder.
That's a lot.
And I also heard that there's environmental housing concerns
Yes,
as well, in terms of things that are in,
old
unfortunately.
houses.
Yeah.
Mhm.
Right,
So the
right,
environment definitely has to be.
That's right.
Yes,
right.
yes,
And speaking of things that we don't want the kids to be walking around with, guns is one of
guns.
them. Really a
It's a,
health
yeah.
problem. Mhm.
Mhm,
So it
mhm,
kind of goes back to, Cheryl, when you were talking about the um areas that are safe and inviting, parks
mhm,
and
mhm.
greenways and,
Yes,
lit, that are lit.
that's right.
So
Yeah,
that's definitely what we want to see.
yeah.
Um, Parks
Pedestrian
where,
pathways. Mhm,
uh-huh, parks where people are enjoying the outside.
yeah.
Yeah,
Where those group games are not necessarily the focus. Most of our parks now, they're for group games, whether it's baseball, soccer, or stuff.
right. No,
We need more passive parks where you're just there. You're just there because you want to be there. Um, you know, New York has Central Park is probably one of the best, may not be the safest, but it's one of the best parks,
yeah,
in the country.
yes, it is. Yes, it
It
is.
is,
Mhm.
that type of
Right.
park environment where, you have private spaces and you have public spaces and you have open spaces and green spaces and all those different types of spaces where everybody can be there, but you're not all there together, openly together, just a better park system, I guess.
Yeah.
Right. And then we want reductions in all of the incidents of the major diseases that are permeating our communities. Less hypertension, less diabetes, all
Yes,
of those things that we've identified as being key diseases in our community. We want to see
So,
reductions in all of them.
okay. So we're looking at what we want to see is overall healthy individuals and families in the community.
Right, right.
Just gotten a notice that we will be closing in 2 minutes.
Okay, can you change the slide?
Yes, by all
Okay.
means.
Okay.
You want to move to the next one, Latrina?
Yes, because I think we have the vision. Yeah, we have our vision statement. I'll just have to hammer that out.
oh, yeah,
And what we don't get to discuss in this session, remember, we've got session 4 to begin to think about a lot of this as we send you all the slides.
yeah.
So we don't want to feel pushed.
Huh. Is this a vision? Because
Yeah,
that's definitely.
It's just
Yeah.
really a mind map, actually.
It's like a vision board.
Right.
mhm, mhm.
Those are all the possible assets.
Okay.
I think that we have explored that the
The
group has
community.
a
Yeah,
lot of,
that's it.
I think
Yeah.
so too.
we talked about obstacles.
Mhm.
Mhm.
So in preparation for the next time, I'm going to think about actions even more specific than what we've addressed tonight and come up with some possible problem resolutions. Are we in a good place?
We are,
I
and
think
I
so.
am.
Yes,
Yeah.
I think so.
I love this
Thank
team.
you so much.
In that case, why don't I stop sharing? Latrina, any closing words?
No, thank you, everybody. Yes, thank you all for being here, even though I couldn't be here in the beginning. And Ann, thank you so much for continuing it.
You
The
and I are,
teamwork makes the dream
that's
work.
right.
That's
Our team.
Right.
We're going to leave the room and go back to the broader room, okay?
Okay, thank you
All right.
guys, and see you next time.
All right.
Okay.
All right.
Bye-bye,
See you later.
Katrina.
Bye.
Bye, Ann.
Bye-bye.